Thanks the organizers for inviting me. These are my disclosures. And I had the same question when I started this talk, because what is clinical atrial remodeling? And the very nice and comprehensive overview given by Sander is something that we obviously cannot reproduce or even measure or see or determine in patients. And that's aside from the fact that patients are not goats, most of them. So I would say that for changes for clinical atrial remodeling, that comprises changes in the atrial arrhythmogenic substrate that can be detected clinically. That means that there should be some non-invasive test or even an invasive test in order to quantify and to assess that. And that have implications for the therapeutic strategy to choose. Because otherwise, if there's ischemia, if there's preconditioning in paroxysmal but not in persistent AF patients, which might very well be the case, how is it going to help the patient in getting over the arrhythmia? Further, ideally, it would be a change in the substrate that can be followed up. This is a picture that you all know, of course, from the guidelines, and it indicates that AF is a progressive disease where events occur usually before the clinical horizon has been reached, and it is first documented on an ECG or by pulse taking or otherwise, and then it increases in severity, it increases in frequency, and eventually it ends up as a permanent condition. And we are talking about mostly the period during which you can apply ablation or cardioversion, because the permanent state is something that really no therapy here is given anymore. And it's a progressive disease because partially it's due to the fibrotic substrate, and the work of Maastricht, to which I want to pay some attention, has been mentioned before, because it's very interesting and it has very appealing issues in it, and I wonder why we're not using it all, and I try to answer that. And last year the DCAF study was published, in which they produced this very nice MRI images in which with delayed gadolinium enhancement they can clearly show the amount of fibrosis in the left atrium. They can align the boundaries of the left atrium very nice, and they can reproduce three-dimensional pictures of the left atrium. What you then do is they divide the amount of fibrosis in 4 different stages called the Utah stages, and they produce these dandruff-like distribution of white pickles in the blue left atrium. And this is very convincing. This looks great. The problem is that Maastricht can do it a lot better than the rest of us. And another problem is that this is not an absolute measure of fibrosis, but it's a relative measurement in relation to something else. And if you would increase or decrease the settings of the MR scanner, you would see a different amount of fibrosis. Nevertheless, they did show in earlier work that the location and the amount of fibrosis is associated with the areas of low bipolar electrograms recorded with the mapping catheter during atrial fibrillation. That's really the same spot. The purple areas here are normally voltaged, and the color scale is the low voltage area, with red being the lowest. Further, they showed that there's a relation between this low voltage area not only in location but also in amount of delayed enhancement. And finally, in this early paper, they already showed a relation between the amount of enhancement and the outcome of catheter ablation for AF. Well, in this current study, the DCAF study, what was interesting is that it's a multi-center study, and that all the centers performed the MR scans the way they normally did it, and they were analyzed in a core lab. But the core lab could apparently show the amount of fibrosis. And what they show is that, again, this is not new, that there's a clear relation with the amount of delayed enhancement in the left atrium and the outcome of ablation for atrial fibrillation. And they made a model in which they showed that at lower amounts of fibrosis, the recurrence rate is a lot lower, and if it's increased the percentage of fibrosis, the hazard ratio for AF recurrence increases. And this is, of course, in AF patients, so it's not to be extrapolated to the entire population. So I think what has been shown, and irrespective of what the mechanism is and or how you measure it, but the amount of delayed enhancement MRI detected fibrosis is associated with the areas of low voltage and is associated with the outcome of ablation, and it seems a perfect clinical marker. And there the controversy starts, because as I mentioned before, we have been trying to quantify fibrosis, and it can really be done very well in patients post-ablation, where you see replacement fibrosis in larger areas. You can really image that very well, but to see the interstitial, the perimesial or the endomesial fibrosis, that is very hard, because you have not really something to refer it to, and the areas are a lot smaller than in the ventricle, in which this technique has originally been validated. And I would say, therefore, not fibrosis is equal relating to George Orwell. And that is pointing at our own work. We recently published this paper in Circulation Arrhythmia, where we stimulated the excised left atrial appendage of patients undergoing hybrid ablation for AF. So these appendages are stapled off in the OR, are transported to the laboratory, put in a tissue chamber, superfused with oxygenized thyroid solution, loaded with an optical dye, and then stimulated. And what we saw here, and I will take you through the pictures, what we saw here is that during basic stimulation, that this looks really fine, actually. This is like the picture that Sander showed. It looks like planar activation. It's not very complex. This is a frequency of 100 beats per minute, and this is tissue from patients with varying degrees of atrial fibrillation, but always of longer duration and always resistant to antiarrhythmic drugs and usually to various catheter ablation too. If we now apply premature stimulation close to the refractory period, we see that such lines of block arise here around which the activation turns and forms reentrant circuits. And if you record action potentials, optical action potentials along this red line here, you find these action potentials, and you see that there's a hump in between the early activated area and the late activated area, indicating that the activation is running around it. And this looks like functional block, which can be brought about by refractory periods, by increased anisotropy, by all mechanisms that you can think of and that come from the textbook. But what we found is that these areas of block corresponded to thick strands of fibrotic tissue, and I think you would call them perimesial, we call them just thick, that run in between the strands of myocytes. So during basic stimulation, we don't see this back in the activation maps, but during premature stimulation, these lines of fibrosis anchor activation block and potentially reentry. And we found that there were two types of patients. That were patients that have this thick, thick lines of fibrosis, thick strands of fibrosis in their atrial tissue, and there were patients in which it was more diffuse, whereas the amount of fibrosis counted as a percentage could be exactly the same. And again, remember, this is not control versus atrial fibrillations. It is all tissue from patients with atrial fibrillation. What we then found is, if we look at the percentage of total fibrosis in the tissue, that's the upper panel of the figure here, where here the percentage of fibrosis here, and you see the conduction velocity in the longitudinal and transverse direction in red and blue, versus the activation time over a predefined 2 millimeter line in the activation map. And you see that there's not really very much of a correlation. We can draw a line through it, but this was not significant. It's really a cloud of points. Activation time is here, conduction velocity is there. But if we now compare the change in conduction velocity between the patients with thick strands of fibrosis and those without, we see that there's an increase in conduction velocity in patients with thick fibrosis along the fiber direction, but not perpendicular to the fiber direction. There is a small decrease, but it's not significant. And this points in our interpretation at changed anisotropy in those patients, which can be part of the explanation for the arrhythmogenic substrate. Also in activation time, there was a difference, but that is I don't think, that's hard to translate that to a direct mechanism. Let me put it that way. But it takes longer to activate the left atrium in patients that have thick strands of fibrosis. So we concluded that the structure of fibrosis, and that is in line with what you say, rather than the amount determines the arrhythmogenic properties, and that thick strands of interstitial collagen are associated with functional conduction block following short-coupled stimulation and reentry. To continue on how we can translate what the mechanism of fibrosis formation in the heart is to a clinical useful tool, I found this article by Pepe Khalife, who proposes this scheme. He says, well, atrial fibrillation, it leads to, but also is associated with tissue injury. There are all kinds of cytokines that attract macrophages, and then fibroblasts differentiate into myofibroblasts that kind of excrete extracellular matrix and form fibrosis. And one of the points here is the role of galactin-3, which is a beta-galactoside lectin, and please don't ask me what that is, because that really goes too far for me, but it's a molecule that both attracts myofibroblast and interacts with the TGF-beta-1 receptor, enhancing the production of extracellular matrix. But here we have something that we can measure in blood. So maybe the amount of galactin is a clinical measure of atrial remodeling. And there are several papers, two from a Turkish group, that actually do show that. This is a group of patients in which serum galactin-3 was measured in control patients, patients with paroxysmal AF, and patients with persistent AF, and it shows clearly that the amount of galactin is higher in the group with persistent AF. And in another study, this is the same study. What is interesting about the study is that the percentage of men in the cohort is relatively low. This is less than 50%, and in most AF ablation studies and in most AF studies, the men are in the majority. And what's also interesting is that the amount of galactin here, and maybe this is the kit they used to determine it, is relatively low compared to other studies. And it's completely driven, the difference between no AF and AF, which is significant, is completely driven by the effect on the persistent atrial fibrillation group, as in paroxysmal atrial fibrillation, the amount of galactin in the blood is exactly the same as in control. In another study, they show that there is a relation between the serum galectin-3 level in blood and the extent of atrial fibrosis as measured again with delayed enhancement MRI. And also they show that there is, and this picture is the other way around here, the galectin is on the y-axis. There's an association between serum galectin and left atrium volume index. So it seems, again, like a very nice clinical marker that we can use to assess the substrate for atrial fibrillation. This is basically the same. This is from a French group showing that galectin is higher in persistent than in paroxysmal atrial fibrillation, but also that in cases of lone atrial fibrillation, in the absence of heart disease, hypertension, coronary artery disease, and you name it, it's lower in the AF patients than in those who do have concomitant conditions. We did some work on this too, which has not been published yet, but we found, interestingly, that if galectin-3 would be a factor that is at least driven by atrial fibrillation, then terminating the atrial fibrillation in our hypothesis would result in lower levels of galectin-3, which is not the case. There is no difference whatsoever between the before thoracoscopic PVI and after thoracoscopic PVI galectin levels. And again, we see that in persistent it's somewhat higher than in paroxysmal. And also, the concentration of galectin-3 in serum, here in 4 quartiles, Q1 is blue, that's the lowest quartile, 2 is green, 3 is yellow, and 4 is purple. There's no relation whatsoever in the success rate of atrial fibrillation ablation by means of thoracoscopic surgery and the amount of galectin-3 in the blood. In the same group of patients, we also determined NT-proBNP, which may be a better predictor because here we do see a clear relation where the low levels of NT-proBNP have a better outcome of surgical AF ablation than the high levels. And we also see here, concordant with our hypothesis, that if this is driven at least in parts by atrial fibrillation itself, that it should change over time after restoration of sinus rhythm. And we see that this does happen in persistent atrial fibrillation, but not in paroxysmal atrial fibrillation. So we try to get the feeling on which direction these parameters went, and here you see the galectin-3 concentrations in the upper panel and the NT-proBNP in the lower panel. And please note that the scales here are different, but in paroxysmal AF there's really no relation whatsoever in the NT-proBNP levels before and after ablation, whereas there is a clear decrease in persistent AF. On the other hand, in galectin-3, basically all effects can be seen. There are some patients in which it increases, there are some patients in which it decreases, and overall there's no significant difference. And the only thing you can really say is that it looks like the variation increases a little bit. So about galectin-3, it's not such a perfect marker for clinical use either. We can conclude that it's higher in persistent than in paroxysmal atrial fibrillation, that there are no or limited differences in the concentration between control patients and paroxysmal AF patients, and that it has been shown that it correlates with the amount of delayed gadolinium enhancement on MRI, so that it appears to be a marker of left atrial fibrosis. It correlates with the LA volume index, but the relation with procedural outcome is for now not fully established. There's another thing that is interesting on this hypothesis, and that is that myofibroblasts play a key role in the production of fibrosis in the left atrium. And again, I will take you to our recent paper where we stained fibroblasts and myofibroblasts in this excised left atrial appendages, and similar to the thick strands of fibrosis, we found that there were patients with many fibroblasts in their tissue and patients in whom there were not really so many, and that there was a relation between the change in conduction velocity and the amount of, it's not the amount, it was a qualitative assessment, and the density of fibroblasts in the tissue, where many fibroblasts were associated with an increased longitudinal conduction velocity, and there was no difference again in the transverse conduction velocity, pointing at increased anisotropy. But then we tried to stain for myofibroblasts with alpha smooth muscle actin, and the only places where we found alpha smooth muscle actin was in co-staining with CD31 around the vasculature, and we couldn't find basically one single myocyte in the left atrial tissue, sorry, not myocyte, myofibroblast, in the left atrial tissue of those patients with atrial fibrillation. Bringing up the question how important this is in advanced AF. They potentially played a role in establishing the substrate, but once the patient is that far that he will undergo ablation, maybe they are gone. So there's an abundant number of fibroblasts in the left atrial appendage of patients with atrial fibrillation that is associated with the thick collagen strands that I showed you before. And we could not find any myofibroblast in left atrium from AF patients. And the clinical relevance of myofibroblast in a fibrotic substrate of advanced AF, and I put the word advanced in between here because I think that the patients that we see have a different type and at least a different duration of AF than most animals in the study, remains to be established and is for now not completely clear. I'd like to bring your attention to one other thing, because as a doctor, we're not treating atria, but we're treating patients. And I would say maybe we should look at remodeling at all and look at things that can be detected, have implications for therapeutic strategy, and can preferably be followed up. And if you then think about clinical remodeling, one thing that comes to attention is overweight. And indeed, the guidelines point us at treating upstream the concomitant conditions that lead to AF or may aggravate AF. And recently, during the last ACC, a study from the group of Prax Sanders was published, in which they offered weight counseling and a weight clinic to those patients in their AF clinic with a body mass index of higher than 27. And they included 355 patients after excluding many patients due to exclusion criteria, and the other patients between here presumably had a normal body weight. And they did an analysis on the group that showed more than 10% weight loss, 3 to 9% weight loss, or less than 3% weight loss, or actually weight gain. And what they found was very interesting, because they found that this has an effect on left atrial size, left atrium volume. You see the groups here again. No weight loss or weight gain, 3 to 9%, and more than 10%. And you see that during follow-up, the left atrium volume decreases in a dose-respondent manner with the amount of weight loss. The amount of high-sensitive CRP decreases. The symptom burden and the global well-being, both assessed by scores, change in a dose-dependent manner with the weight loss. And the amount of atrial fibrillation accordingly was influenced. And this is just the follow-up without any intervention. And they found that 50% of patients, 46% of patients admitted to an AF clinic because of symptomatic AF were free of atrial fibrillation without antiarrhythmic drugs or ablation in the group that lost more than 10% of their weight. And if you allow antiarrhythmic drugs or ablation, these numbers are obviously better, but the relation really remains the same. So that brings me to my conclusions. Left atrial fibrosis is an important substrate for atrial fibrillation, and I think there's no discussion about that. There's discussion about how can we assess it in the patient. And that is a challenge, and that remains a challenge despite the very nice papers of Marouche, despite the fact that there may be biomarkers in the blood that we can use. Several biomarkers have prognostic relevance, but I don't think we have found the silver bullet yet. And my general advice would be that we should think of remodeling of the entire patient and not only of remodeling of the left atrium. I thank you for your attention.
Thank you very much, Joris. Very nice presentation. I think we all definitively agree with your last remark, I'm sure. Are there any questions? Harry again.
Thanks very much, Joris, for this wonderful presentation. And also, so we, as clinicians, we are still on the modest side when it comes to prediction of or establishing relationships. Your galectin-3 story is extremely interesting, and I think you did an important work there, looking at patients whom you ablated with via VATS. My question is, obviously you're looking at sort of end-stage patients because they need a VATS for the AF. And one of the ways we also should go into, our thinking should go towards predicting the patients who have a short career of AF. They are coming in now for the first time, for instance. And in those patients, we are not very sure about their course. We've done studies on progression of AF, which is then the change from paroxysmal to persistent, which we think is a bad thing if that happens. And we might, and I want to hear your opinion about that, more look at the importance of biomarkers like galectin-3 in patients who present with AF and maybe may distinguish their patients which are going to progress or not. What's your opinion?
Thank you for your question. And let me start with fully agreeing with you that it's very important to distinguish those patients in whom eventually any treatment will be futile because they will progress anyway, from those patients who can be saved. And I also agree with you that currently we're not very well able to do that. I would not know if galectin can be used as a biomarker here, but that's definitely a testable hypothesis. I don't know about literature there. I do know about an upcoming registry in which that could excellently be tested.
That's right. Thanks very much.
Yuri, please.
Joris, great presentation. So you focused on the left atrial appendage in your study. Obviously, that's the only tissue you can get during this surgery. But I always find the left atrial appendage also a kind of strange structure in the heart, because if you, for example, during an ablation, you see a lot of fragmentation in the heart. The only structure where there is no fragmentation is the left atrial appendage. So could you maybe speculate a little bit on this difference, and maybe can your results also be seen in the rest of the left atrium? What do you think?
Thank you for your question, Yuri. There are two questions that you asked. The one is, why do we see organized activity in the left and right atrial appendage? Because the same accounts for the right atrial appendage where we put our pacemaker leads. And is what we see in the histology of this tissue representative of the rest of the left atrium? We are currently working on that last question by doing a post-mortem analysis of patients who had atrial fibrillation versus those who didn't, and compare different areas in the atrium in order to exactly answer that question and be able to establish a relation. Sure. It seems like in terms of fibrosis there is a relation. Then your second question is the fragmentation of atrial activity, which is of course not only tissue but also activation direction dependent. And in a funnel-like structure like the atrial appendage, there are potentially fewer directions of activation possible because activation can only go in. That is at least how I try to explain it to students when they say, well, but it looks very regular on the pacemaker lead. So yeah, but you look at the right atrial appendage and activation, wherever it comes from, it can only go in and it can never be too complex in this small area. This is a hypothesis. I don't know for sure if it's true, but the first part of your question, that will be answered.
Because, I mean, thank you. On the other hand, there's a lot of trabecularization in the left atrial appendage, so you could also suggest that there's a lot of 3D conduction, so maybe Uli has also an idea on that, but that could also, that would actually lead to the opposite direction, that you would see more fragmentation, but it's puzzling.
Okay, any further questions? Yes, Sander, last question, and then we have to move on to the live presentation.
Very short
Sander,
question.
please.
Thank you very much for the beautiful presentation. About the galectin, I guess it's not specific for the atrium, it's also produced in other tissues. How long after the ablation procedure did you measure the galectin levels?
I don't know that for sure, but between 3 and 4 months.
Okay, so it's long enough to really...
The patients come back for, they get the lab form 3 months after ablation.
Okay.
So, but they don't have to do it on the same day. But it's not the day after or a week after.
Yeah,
so
yeah.
it's we think that it should have been changed if it would change.
Okay.